Welcome to the Surgery and Therapy Summit and my interview with Shrikant Chinchalkar. Shrikant, welcome, and thank you so much for giving us a little bit of your time so that we can learn about you.
Thank you, Robyn. You always do a wonderful job doing this, putting this together. And I admire you for your courage and, of course, dedication doing these type of sessions for the therapist globally. So thank you. Thank you for bringing me on your board. Thank you.
Oh, thank you. That's so lovely. So lovely to hear. Thank you so much. You and I have been colleagues and friends for a long time. Well, actually, we first met in person in Berlin 4 years ago.
Right.
And we recently got to see each other again in London, which was so wonderful, as brief as our catch-up was. And you have always been so generous with your knowledge, and just you're so humble in your teachings. And it is really an honor for me to have you present on the elbow at the summit. And it's just also an honor for me to let other therapists learn a little bit more about who you are and what your journey has been in your career to bring you to where you are today. So do you want to tell us a little bit more about your journey?
Sure. First of all, I must say that I graduated about 50 some odd years ago. I may look or sound too old for that, but anyway, it has been an interesting journey for me right after I graduated from my OT school. Interestingly, my first job was in a missionary hospital in northern part of India, where I had an opportunity to work with surgeons who were trained by Dr. Paul Brand. And I had heard about Dr. Paul Brand afterward, but people used to say this is a brand technique and this is a brand. So I thought this was kind of some kind of a brand they are bringing into medical practice, which was kind of interesting. But soon I found out that he worked in Vellore, that is southern part of India, working with the Christian Medical College and local medical hospital. And he trained a number of surgeons there locally, and those surgeons traveled around India and then started working in different centers. So I consider myself very fortunate that I was groomed by the godfather of hand surgery, what he was called back there in India. And I remember that first time when I entered the hand surgery clinic, I was introduced by my boss, who happened to be a Scottish lady. I just recently met her in Scotland as I was traveling in northern part of Scotland. So we met after 49 some odd years, but it was interesting to see. So see her again, but she was quite instrumental in bringing me to the hand surgery clinic. She introduced me to one of the surgeons and said that this fellow is a new recruit. She called me a recruit, so that was kind of amazing that kind of a word was used for me. I mean, recruit sounds something unusual, so as if I was recruited for some kind of an army or that kind of stuff. But anyway, so this surgeon who performed hand surgery asked me a question. He said, "Oh, I'm doing this 4-tail brand transfer for this patient tomorrow. And after that, I'll be referring that patient to you. And I'm wondering whether this patient will be able to use a typewriter." Now thinking, since I had heard about Dr. Brand, I was thinking that this fellow is going to perform the surgery. Obviously, the surgery will definitely be done very well. And then this patient definitely will gain those lost abilities that he had. And boy, I was so wrong, because I didn't know what the 4-tail brand transfers was, and my colleagues standing there, not OT colleagues, but surgery colleagues were just smiling at me, thinking that what kind of a recruit is he? So that was my turning point. But I worked there for 2-3 years, and it was very enjoyable having worked with different types of complex hand injuries, mutilating injuries, and so on. So I was really groomed by those people, and they made me think how and why I should be treating these patients somewhat differently. So anyway, after working there for 2-3 years, I moved on to another center. And this was the biggest hospital in India called Safdarjung Hospital, where I worked on the hand program. And again, I acquired quite a number of skills at this facility and moved on, and then finally ended up in Canada. So this was after 7 or 8 years of my practice in India. And of course, I considered myself lucky and thinking that, oh, well, I have acquired so much of skill, I should be able to practice anywhere in the world. However, things were different in Canada as compared to what the things were in India in terms of practice. Now, in India, of course, we had to use some locally available material. For example, to make a splint, we used bamboo sticks. We used some leather material, whereas when I came to Canada, it was all thermoplastic, and I had never ever experienced working with thermoplastic, in India. So that was a new learning experience. And there's a saying that you never stop learning. And even though I've worked for 50 years now, I'm still learning lots on an ongoing basis. So anyway, after working at the center in Canada, that was in Winnipeg, I moved on to Ontario, and that's where I had an opportunity to work with some of the nation's bigwig or big surgeons. We call them bigwigs anyway. So big surgeons such as Dr. Ralph Mangtello, Dr. Robert Salter, Dr. Susan McKinnon, Dr. Brian Boyd, and of course, they were bigwigs in their own field. They were plastic surgeons as well as orthopedic surgeons, and I learned a lot from them. Yeah. Now, coming to the elbow as a topic that you have assigned to me, I feel that elbow is still being mismanaged or not properly managed. I shouldn't say mismanaged, but not properly managed by a number of healthcare practitioners, including occupational therapists as well. So I remember when I started working at Roth-McFarlane Hand and Upper Limb Center in London, Ontario, I met Dr. Graham King, who was hired to perform elbow surgery at our facility. And it used to be a trend that after surgery or after elbow trauma, the elbows needed to be immobilized for a certain length of time. And then every patient or number of patients who were immobilized for certain length of time, they obviously were quite stiffer. They had limited mobility, and it was kind of a struggle, not only for the surgeons, but also for the therapists as well as patients to have or regain that motion. So I spent quite a bit of time reading about elbow biomechanics, looked at elbow anatomy in details, attended some sessions, surgical sessions, which were carried out by Dr. Graham King, and changed the method of management especially. So now, of course, we start moving elbows relatively much more earlier, within 1 to 3 days, or maybe within first 5 days post-injury or post-operatively, so that we can have successful results. We know that elbow was always called as an unforgiving joint. But if we really understand the elbow anatomy or complex elbow anatomy and see which structures are injured and which structures tend to physiologically create joint stiffness, we can say that if we understand that physiology of contracture formation or stiffness, if we change that around and start moving these patients early, we can definitely gain quite a few successful results. And of course, I can very well say that the treatment that we offer to these patients at Roth-McFarlane Hand and Upper Limb Center definitely made a big world of difference in the patient's life, as well as the life of individuals who work along these individuals who have an injury or who have had surgical interventions.
Well, what an incredible story. You're so fortunate to have worked with the big wigs, that is for sure. I read so much of Paul Brand's work when learning the casting motion to mobilize stiffness technique. He had an enormous influence on the understanding of why Judy Caldert's technique works. And yeah, what an honor for you, and especially to have moved from India to Ontario to work with Mr. McFarlane. And so that is why I also selected the elbow joint for you, because I recall a surgeon once saying to me, you only need to look at an elbow and it gets stiff. So early mobilization is definitely the way forward. And there's so much involved, particularly with the ulnar nerve, because, the ulnar nerve is the most sensitive nerve around that joint, and, can just have devastating impact on the patient's hand if it's damaged. And also if, we do not apply the right rehab methods.
Yes. I'll comment on that. All the nerves that cross over the elbow joint are susceptible to some kind of trauma. We know that if you look at the posterior intraosseous nerve that sort of crosses over the radiocapitellar joint, and somewhat distally, the radial nerve or posterior intraosseous nerves are likely to get traumatized or irritated because of the type of injury the patients have suffered as a result of either a fall or as a result of maybe mechanical changes that goes on due to an overuse. And secondly, we know that your median nerve crosses over anteriorly around the elbow joint. So all these three nerves, including radial nerve, which then splits into a posterior intraosseous nerve, then anteriorly you have a median nerve that also gets traumatized or get compressed. And then you must have heard about pronator syndrome, or now people call about bicipital epineuritis, entrapment neuropathy of the median nerve, and then medially you have an ulnar nerve. An ulnar nerve usually gets injured in various regions or get compressed in various regions around the elbow joint. And in earlier days, I used to see these patients where the ulnar nerves were never ever transposed following an elbow trauma or distal humeral fractures, but now routinely, in order to prevent late complications with elbow trauma, the ulnar nerve is often transposed when the surgeon suspects that it is likely to produce complex situations after we start mobilizing the elbow joint inflection. So I can very well understand all these three nerves that cross over the elbow joint especially require special attention from the surgical point of view as well as from therapy point of view, so that we are making sure that we don't compromise nerve conduction and muscle denervation of any kind.
Yeah, and it's important whether you're working with when you're working with the wrist as well. But I've seen in my practice a professional golfer was referred. A therapist was treating his wrist and was convinced the wrist pain was coming from the elbow, and did very deep soft tissue mobilization and actually gave him a radial nerve palsy. And also, we also know that patients are often with carpal tunnel syndrome misdiagnosed when they actually have Lacerta syndrome. And so it is so important that as a hand therapist, you are very proficient in managing and understanding elbow pathology, and also going all the way up to the shoulder and the neck. And there's a lot of injuries that ricochet. So, patients that fall onto an outstretched hand and fracture their distal radius, you're going to have injuries ricocheting up to the elbow. And I think the elbow is often neglected. The therapist is so focused on the wrist and the distal radius fracture, that they're not going back up to the joint to see what pathology is starting to be demonstrated.
Yeah, interestingly, if you look at the elbow joints, it's in the middle of two joints, approximately the shoulder and distally the wrist, and then of course the hand joints as well. So whenever your elbow joint becomes stiffer or loses motion, it definitely affects your glenohumeral joint. It definitely affects your forearm rotation. It has an effect on your mobility or motion of the wrist as well, and hand function is compromised. But on top of that, we don't think that elbow joint is likely to produce any parascapular changes as well. Because if you look at the elbow joint, which has limited flexion or limited extension, as well as flexion, you tend to compensate with shoulder, and you tend to have secondary joint, proximal joint, especially shoulder joint stiffness, and then you lose internal external rotation and ability to use your entire extremity just because your elbow joint is stiffer. And on top of that, if your elbow joint is stiffer, you tend to produce compensatory motion by using your wrist, especially towards ulnar deviation for specific activities. So it's likely then you may have some drudge pain and discomfort, and your carpal kinematics as a result of elbow limitation is likely to produce carpal kinematic changes. So you can see that elbow joint not only has an effect on elbow itself per se, but forearm rotation, your wrist motion, as well as glenohumeral and your postural, especially postural changes as well, because of the elbow joint being limited in terms of motion and function.
Yeah, absolutely. So there's a wealth of knowledge that we can learn from you. And are you going to be focusing on a few disorders of the, or I should say diagnoses, following your clinical anatomy description? How are you going to structure your talk?
So my presentation will be focusing briefly on anatomy, because anatomy people have already read or people have known anatomy well, but my main focus will be on the medial collateral ligament complex, the lateral and collateral ligament complex, and I'll speak in general about elbow fractures and dislocations and what emphasis we should be giving in terms of mobilization of the elbow, and then how we should focus on motion of the wrist and proximal joints as well. But my main focus will be more on the elbow itself. I'll be talking about maybe briefly about the terrible triad or elbow fracture dislocation for people to understand the elbow biomechanics from the anatomical point of view.
Okay, that is brilliant. Really, really excited about that. So therapists should really prepare for your talk by brushing up on their anatomy so that they can learn those therapeutic techniques from you, because this is quite a practical summit. We do want therapists to be able to, in their next clinic, take something that they've learned from your session and apply it to their patient. So yeah, thank you very much for focusing on that clinical application.
Yeah, most welcome. And if you're interested, I can share some of my elbow publications with you. I mean, there are not that many, but some that mainly focuses on terrible triad, as well as elbow instability, and the other being looking at the drop sign, especially of the elbow joint. Yeah.
Oh, no, that's good. Because I know personally I've struggled with patients that have had a fracture and are very stiff. And one thing that you learn as a therapist is that you cannot be aggressive with the elbow.
No.
You've got to really give it time, but also balance that with the early mobilization principles, and of course prioritizing any potential nerve compression or issues around the nerves.
Right. For the longest period of time, the therapists were blamed for creating heterotopic ossificans, but that is not true. There's an underlying pathology that contributes to HO, or heterotopic ossification formation. And I've had a number of discussions with our surgeons initially when they said that, oh, you must be mobilizing the elbow joint too aggressively, I used to tell them, no, I'm just only performing active assisted motion to begin with, which didn't involve passive range of motion or mobilization, so to speak. However, if people have a typical type of a fracture where there is a periosteal disturbance or having a trauma that has gone into severe amount of displacement, these patients are likelihood of producing heterotopic ossificans. And why these people produce HO still is unknown. So the therapists are definitely not the culprit for producing heterotopic ossification. I would just wanted to make that clear to everyone, because this has been labeled, this has been a blame put on the therapist for being too aggressive. However, there are stages when you need to be aggressive depending on the clinical situation. However, we must be cautious enough not to produce or create an inflammatory response as a result of mobilizing a particular joint.
Absolutely. Well, thank you for clarifying that, because it's wonderful to be able to categorically state that the therapists are not responsible.
Right.
Yeah, because it can be quite stressful for the therapist.
Mm-hmm.
Well, Shrikant, thank you very much for your time, and we are really looking forward to your lecture and learning more. Thank you.
Thank you, and thank you for giving me an opportunity to be part of your summit as well. Thank you.
It's a pleasure.